Colpotomy closure. Do suture and stitching technique matter? In urogynecology, there are no data on the preferred suture used to close colpotomy in the anterior compartment, nor if the different timing of resorption of the suture may have a role in the incidence of complication. So the aim of this study was to assess wound healing comparing the rates of complication in different types of suture and suturing technique. So this is a multi-center prospective study involving 8 different urological or gynecological departments and involving 12 surgeons skilled in urogynecology. All women were naive for vaginal surgery, and surgical procedures were anterior vaginal wall repair by native tissue or by polypropylene mesh for pelvic organ prolapse, and for stress urinary incontinence, positioning by synthetic middle urethral sling. Sutures used were Vicryl 2.0 or Vicryl Rapid 2.0, and stitching techniques compared were running interlocking and interrupted stitching. Surgeons performed the type of suture and the kind of stitching technique usually used in the daily clinical practice. The follow-up was done in the outpatient clinic at the discharge at 30 days and at 3 months, but patient could call the surgeons if something was going wrong. Suture was considered failure in case of wound descent or in case of taper max extrusion at the level of the area of suture within 30 days of surgery. We recruited 1,040 patients, 703 had anterior vaginal wall repair, 97.8% with native tissue and 12.2% with mesh implantation, and 337 had the stress urinary incontinence and had the middle urethral sling implantation. About patients with the pelvic organ prolapse, they had more used the kind of stitch that was Vicryl 2.0, 61.2%, but we had the same cases of wound descent. And running interlocking was the most used suture, stitching, and we had the same wound descent in both the groups. About patients with the stress urinary incontinence, we had the same number of stitch use, Vicryl 2.0 or Rapid, and we had almost the same number of wound descents. And about the stitching technique, we had much more interrupted than interlocking, with a higher number of wound descents in the interrupted, but this is a bias due to the lower number of running interlocking. Results show also that complication by clavien endoscale were 3 cases for grade 3 complication, and at 3 months none of the patients had wound complication nor vaginal discharge or dyspareunia due to the presence of residual Vicryl sutures. Most of the complications had surgery to be closed, just one had a conservative management. In anterior vaginal wall repair, Vicryl 2.0 was the most common used suture, and running interlocking was the most used performed stitching techniques. In middle urethral slings, Vicryl 2.0 and Vicryl 2.0 Rapid were almost equal used. Interrupted stitches were the most used. One distance was rate was low in the groups, with higher prevalence was found in middle urethral slings, and the suture and stitching technique used did not impact remarkably on the outcomes. In conclusion, this study showed that outcomes of patients did not relevantly change according to the suture and stitching technique used. Thus, our data documented how the suture can choose suture and stitching technique according to their personal preference. So, thank you very much for the attention.